Hello, everyone, and welcome to the Children's Cardiomyopathy Foundation's webinar, ICD Considerations for Pediatric Cardiomyopathy Patients. My name is Gina Petty, and I am the Executive Director of the Children's Cardiomyopathy Foundation. CCF is a nonprofit organization dedicated to finding the causes and cures for pediatric cardiomyopathy through the support of research, education, awareness, and advocacy. Established in 2002, CCF has grown into a global community of families, physicians, and scientists focused on improving diagnosis, treatment, and quality of life for children with cardiomyopathy. Your questions are encouraged and welcome during the presentation. You may submit questions through the question box located on your control panel. We'll reserve the last few minutes of our time together to take questions. You're welcome to submit them at any time during the presentation as you think of them, and then we will read them out loud at the conclusion of the talk. This webinar is being recorded and will be available on the CCF website for those who are unable to attend live, or if you would like to review it at a later time. We are thrilled to be joined today by Dr. Heather Giacone and Dr. Lauren Schneider. Dr. Heather Giacone is a pediatric electrophysiologist at Stanford University, Lucile Packard Children's Hospital. She grew up near Boston, Massachusetts, and completed her medical training in Arizona, and then cardiology and electrophysiology fellowship at Stanford. She has a significant interest in medical education, diversity initiatives, and does research on specific congenital heart disease populations that have ventricular arrhythmia. She is mom of two boys, James and Thomas. Dr. Lauren Schneider is a clinical associate professor in the child and adolescent psychiatry and pediatric cardiology departments at Stanford University, Lucile Packard Children's Hospital. She completed a fellowship at Stanford University and is a member of the Maternal and Child Health Research Institute. Dr. Schneider's research interests focus on psychological considerations for pediatric transplant, ventricular assist device, and ICD patients. We are thrilled to have you both joining us today. Thank you for coming to share your time and expertise.
All right, thank you so much for having us today. I'm going to go ahead and share my screen. All right, thank you again. My name is Dr. Heather Giacone, like she said, and it is an honor to be able to talk with you all today. We are going to discuss ICD considerations, and specifically for pediatric cardiomyopathy patients.
Good morning. My name is Dr. Lauren Schneider, and I am also honored to be a part of this presentation today. Thank you.
We do not have any disclosures, financial or otherwise. We will be discussing specific devices, companies, or resources that may be useful to you as a patient, but please know that this is not a specific endorsement for any of those products, and there are other ones available that are out there. Our objectives today are to provide you with information about ICDs and why an ICD may be recommended for you or for your child. We'll discuss some risks and benefits of the different types of ICDs that are available for use, and really dive into what is it like living with an ICD. Our goal of this presentation today is really to empower you to encourage discussion with your provider and your healthcare team. I do want to make mention that we will be discussing sensitive topics today, such as cardiac arrest and a risk of death. So first of all, we're going to start off, how does the heart beat normally? I get this question a lot in my clinic, specifically from patients. So if you can see my mouse, this is a cartoon drawing of a heart. The heart has two top collecting chambers called the atrium, and we have a right side and a left side. And then we have the bottom pumping chambers of the heart down here called the ventricles, the right ventricle and the left ventricle. Now, if you see these blue lines and dots, these are the specific parts within the heart that send itself electrical signals to tell it the muscle to beat. So the normal pacemaker of the heart is up here from the SA node. It sends a signal down to the middle part of the heart where the AV node lives. and then it travels down to the ventricles to have a coordinated beat from the top part of the heart, followed by the bottom pumping chambers of the heart. Now, of course, this is a cartoon. We do have colleagues actually within Stanford Medicine who have dedicated their lives to really looking at how the conduction system works. And this is actually a model of stained conductive tissue. So you can see it's pretty accurate in terms of how it looks, but medicine has come a long way. So how does this look on something that you all may be familiar with, an EKG or ECG, also called an electrocardiogram? What this looks like are three specific waveforms. And so you have this first wave here that correlates with the top contraction of the atria. You have this large spike in the middle, the QRS complex, which really electrically shows us the impulse from the bottom ventricles. And this final deflection is how the heart electrically resets itself. So we call this normal sinus rhythm or a normal rhythm of the heart. Now, what do abnormal rhythms of the heart look like? Because we'll be talking a lot about arrhythmias or those abnormal rhythms of the heart. Two I want to focus on today are ventricular tachycardia and ventricular fibrillation. You may have heard these terms before. Ventricular tachycardia means fast heart rate and coming from the ventricle or bottom pumping chamber of the heart. Think of this as an area of the heart down here, either side, that sends out very, very fast signals, either goes around in a circuit or really just beats hard and sends those signals, and it overtakes the normal conduction system or the normal electrical process. So you can see normal beats here, one abnormal looking beat, and that's actually one early beat coming from the bottom part of the heart, followed by very fast waveforms looking up and down. And this is actually a form of ventricular tachycardia. And the reason that we're going to be talking about these abnormal rhythms is that these abnormal rhythms do not effectively allow the heart to fill with blood and pump that blood around the body, and it can lead to passing out, fainting, or even death. There's another type of rhythm called ventricular fibrillation. And this is when the electrical impulses again start from that bottom part of the heart, are chaotic in nature. And the muscle itself almost starts kind of quivering because it's not effectively delivering blood to the body. So how does my healthcare team monitor me for arrhythmias? Well, like I said before, you can do an electrocardiogram or EKG. They might recommend rhythm monitors for you. This can be internal, or you can undergo a procedure to have an implantable device. So common rhythm monitors that we use are patches on top that stick on the skin. They can stick anywhere from 24 hours up to about 30 days, depending on the type. And this is what it looks like, a small implantable loop recorder, and that goes under the skin on the chest. And both of those are ways to monitor the rhythm of the heart on a more long-term basis, because electrocardiograms, as you know, are done in the office usually, and it's just a snapshot in time. So while it gives us a massive amount of information, it doesn't always tell us the whole picture. The last one is exercise testing. So you have these same EKG stickers placed on your chest, and you may be on a treadmill or a bike. And this is for us to get a sense of how does your heart behave when we're stressing you and the body and we're making you exercise. And that also gives us more information about risk of other types of arrhythmias. So let's go into what is an ICD. An ICD is an implantable cardiodefibrillator. And what this is a device or a machine that monitors for these life-threatening arrhythmias like we talked about. And once it detects these, it can treat these life-threatening arrhythmias by supplying an energy source to the heart or a shock. Now, many of you may have gone through CPR training or be familiar with an automated external defibrillator. Some of you actually may have these in your home or your schools. And this is the machine here, externally connected to these pads that you place on the chest of someone who is unconscious. And again, it detects, monitors and treats for these life-threatening arrhythmias. Now, switching over to this image on the other side of the screen, this is really one type of ICD. And so just like the machine here has its power source, this is the machine's power source for the ICD. And so we call that a battery or a generator. It's connected to a lead that goes through the veins and connects into the bottom part of the heart on the inside. And I'll go through how this works in just a minute. So a common question is, how do these machines see the abnormal rhythms, and what does it do? What does it look like? So I provided two strips for you as to an abnormal rhythm. So you can see ventricular fibrillation. At this point where the star is the machine has now detected that abnormal rhythm, provided energy, and really restored the rhythm. And the same thing on this side that is done for the implantable cardiodefibrillator. So both of these machines work similarly, but the implantable cardiodefibrillator you can carry with you at all times. So what's really the purpose of an ICD? It's to prevent a sudden cardiac arrest. So sudden cardiac arrest is when the electrical system of the heart stops working, or if there's, again, a life-threatening arrhythmia that doesn't provide enough blood flow to the body. In children, a sudden cardiac arrest is most commonly because of an abnormal rhythm, whereas in older patients and adults, you're really focusing on heart attacks as the main cause of cardiac events. And that's because of a blockage of the arteries that supply the heart. So it is a little different between pediatrics and adults. We do know that about 1 in 10 people survive a sudden cardiac arrest outside of the hospital without an ICD. But with an ICD, over 95% live. So how does, again, an ICD work? This has little electrodes or little special areas on the end of the lead that monitors for the arrhythmia. It talks to the generator and sends itself signals. And in here is a specific algorithm from the device itself that works on detection for the arrhythmias. And if it meets specific criteria that physicians set, then it will say it meets criteria to deliver that shock. There's a thicker part of this lead here called the coil, and that's where the energy is sent through the lead, but it actually serves as a vector, or the energy is supplied through this way as well. So it's important that physicians consider when we're talking about implanting an ICD as to what that vector or what that path looks like between the lead and the device itself. So one of the biggest questions that I get in my clinic is, when is it the right time to get an ICD? So I want to just reiterate that the goal of pediatric cardiologists are to keep your heart healthy and prevent sudden events or sudden cardiac arrests from happening. And the way that we do this is trying to identify risk factors that we know from medical literature that may put children with cardiomyopathy or other heart disease at higher risk for sudden cardiac arrest. So your provider may start this conversation about ICDs very early on after meeting you, or they may hold off on these conversations and discuss other parts of your disease process before having this conversation. There's no wrong time to start introduction of this type of conversation, but know that that kind of varies depending on who your provider is, and that's okay. But if you ever have questions about this, even if they have not brought it up, it's always okay to bring up those questions to them. Fortunately, in 2021, the Pediatric Society for Electrophysiology came together and really sat down for many, many months and years to put together all of these risk factors to provide some basic guidelines for us as electrophysiologists and pediatric cardiologists with all of the current literature. So you may be asking yourself, but why am I at higher risk for arrhythmias or sudden cardiac arrest? So we know that patients with abnormalities of the heart muscle, and it can be for a variety of different reasons that I listed, that those abnormalities of the heart muscle can interfere with how that electrical process happens. And then you might be at a higher risk of having these types of arrhythmias. So it can be scar within the heart, a thicker heart muscle, such as hypertrophy, a stretched heart muscle, such as dilation, ischemia from inadequate blood flow to the muscle itself, or a buildup of fat or other substances within the cells of the heart. And then also you may have a normal heart or be absolutely okay without arrhythmias. And then as your disease progresses, and if your heart is struggling, it can then show us these types of arrhythmias as well. And so a higher risk of arrhythmias are associated with heart failure. I really want to stress that every patient is unique. I'm going to go through different types of cardiomyopathies because I think it's very helpful to know or have a general understanding that cardiomyopathy does not mean one diagnosis. It's what we call an umbrella term, and it is encompassing many, many different types of patients. But even patients within one category of cardiomyopathy, such as hypertrophic cardiomyopathy, may present very differently and look different from each other. So while it is extraordinarily helpful to talk to other patients, to talk to other families, and understand their process throughout this entire ICD life, pre and post, just know that their indications for a pacemaker might be a little bit different than yours, just depending on what the physician sees in their specific disease process. I'm going to touch on just 3 of these, but I'm absolutely open to questions on other ones. And if you're curious about more information, please feel free to email me. So we'll talk about hypertrophic cardiomyopathy, dilated cardiomyopathy, and then left ventricular non-compaction. So hypertrophic cardiomyopathy affects about 1 in 500 individuals. We know that the childhood annual incidence is about 0.5 out of 100,000 individuals. It's the second most common cardiomyopathy in childhood. And this is really an abnormal muscle architecture. And so as you can see here, this is looking at the heart muscle, normal heart muscle, as it forms. And it's nice and linear and formed and very organized. But as that muscle thickens, as you can see right here in the middle of the heart in this patient, this abnormal process causes a disarray of those nice myocytes or those nice cells of the heart. And that abnormal architecture over time can lead to increased arrhythmias. We know that ventricular tachycardia specifically can occur in about 9% of patients, if not more. And sudden cardiac arrest is a real risk for patients with hypertrophic cardiomyopathy. If left untreated, we know that about 60 to 70% of patients with hypertrophic cardiomyopathy can experience a sudden cardiac arrest. But these, again, because this is a very unique population and you can have thickening of different parts of your heart, those rates can really vary quite widely. So now going back to some data, what do we know? What are the risks? So we have a class system of recommendations. And by no means do I want you to memorize all of these. This is more so just how does the physician think about risk factors for me with hypertrophic cardiomyopathy. So the classes give us recommendations. A class 1 is a very strong recommendation saying you should have an ICD. And so this is patients that have had a sudden cardiac arrest before or those with ventricular tachycardia. Class 2, kind of going down for a strong recommendation if you have 1 or more risk factors of unexplained fainting, massive LV hypertrophy. Classically in adults, this is over 30 millimeters of your thickest area of septum. In kids, it's a little different because we take into account the size of the child. And so you may hear your physician talking about Z-scores, and that again takes into both height and weight to account the body surface area. And this is a little debated, but family right now of early hypertrophic cardiomyopathy related deaths has been known to have a risk factor. It's a little less so now as we're uncovering different genes. So some genes that are inherited or passed down within the families may have a stronger association than others. And then we always have to consider other things with the heart. And so consideration of an ICD if you have extensive scarring on MRI or extensive scarring on your heart by MRI or poor function of the heart are also indications that we should start to identify these risk factors, have these conversations, and potentially recommend an ICD. Let's switch gears to dilated cardiomyopathy. So again, this is a cartoon of a normal heart, and you can see here that this is a thinning of the heart muscle, an enlargement of this chamber. This occurs in about 1 in 2,500 individuals. These patients can, in some studies, have a high incidence of ventricular arrhythmias, up to about 40%. But patients with dilated cardiomyopathy, we've come to realize that really the mainstay of treatment is making sure that they don't go into heart failure. And so sudden cardiac arrest in these patients are actually a little less common. Again, very similar with actually all of the categories. If you've had an arrest before or have sustained or long episodes of ventricular tachycardia, that is a recommendation for an ICD. For dilated cardiomyopathy, really now what moves up on the chart is the poor heart function. We do know in some studies that ICDs do, of course, prevent sudden cardiac arrest and can lower mortality by up to 30% or so. But we have ongoing work as a medical community to identify these risk factors, because currently in pediatrics, ICDs for what we call primary prevention, so to prevent any of these sudden cardiac arrest episodes from happening, it hasn't been truly documented in pediatric patients that an ICD improves survival in patients with just passing out. So that one, although it's really recommended in hypertrophic cardiomyopathy, that one is not on the list for dilated cardiomyopathy. So you're already starting to see there are differences within cardiomyopathy patients and what types of risk factors that we're looking for. Let's jump over now to left ventricular non-compaction. And I think out of all of the groups, left ventricular non-compaction has the most heterogeneous group, meaning that this is a wide variety of how people are affected by it. Some people can be one small area of the heart. Some people can be very affected by this. So what it is an abnormal, again, architecture. You can see this, these kind of what we call crypts or up and down area of the heart within the left ventricle. We do know that if patients with left ventricular non-compaction have decreased function and ventricular arrhythmias, these are very important factors to take seriously, and ICD should be recommended or strongly considered. So let's go over to what types of ICDs are available and which type might be right for me. So I want to point out 3 separate types. Go over them. An epicardial ICD is one that is sitting on the outside of the heart. So again, this is an X-ray instead of a cartoon, but you can see the generator, much like this one, right here outside of the heart. And then this is the lead circling around the back. And so this type of ICD does require what we call a sternotomy, or going through the sternum or the bone on the front of the chest. And so this is done by our surgical teams with assistance from us. Transvenous ICD is one that's commonly used in adults. So we have our generator here, like we chatted about. It goes through the veins and sits within the heart itself. The last type is probably the newest device. It's called subcutaneous ICD. And so you can see the generator on this side of the heart, or excuse me, on this side of the chest. It's all, that one sits between two muscles. And this is overlying the bone, so right underneath the skin. So it's not within any sort of vessels, and again, within the skin. So when do we use these types? What are some things that may get you to be a good candidate or not a great candidate for these types of devices? So again, transvenous ICD, your vessels have to be big enough for this device to fit through it. And so depending on your institution, they'll talk about size and weight requirements and may try to not recommend this until you're a little bit older. And again, this is to just make sure that these vessels stay nice and open, because we do realize that this is going to be a lifetime device for you. These batteries are getting better as the time goes by in terms of our device development, but usually last on the order of 8 to 10 years, depending on the situation. So we usually use an epicardial ICD for our small children, and then subcutaneous or transvenous for our patients that are a bit bigger. The big thing is kind of a hotter topic right now is patients with hypertrophic cardiomyopathy. Because there's such a big mass of the heart sometimes, what can happen is that relaxation or resetting electrically of the heart can look quite tall. And so sometimes these devices can think it's another impulse and think that this is an abnormal rhythm from happening. And I'll talk a little bit about that in a minute. But knowing that these types of devices differ slightly, the physician may send you for additional screening. So this could be CT scans or ultrasounds to look at how your vessels are formed. And then subcutaneous ICDs actually have their own screening process where you have an EKG, you're sitting, you're standing, and you're on a treadmill to make sure that you're a good candidate for them and that these devices will work well for you. So of course, the benefit of an ICD is to extend life by treating these life-threatening arrhythmias. But let's talk a little bit now about ICD-related risks and complications. In any type of procedure, you can have an infection. Over time, there's concern about fracturing or damaging the leads that might need to be replaced. If you have a transvenous device, you can have damage to those veins or vessels. And then, of course, as a pediatric cardiologist, I know that there will be multiple surgeries needed over a lifetime. So we take that into account when we're recommending one type of device for you. Now let's talk a little bit more about inappropriate shocks. So this is when the device sees an abnormal rhythm and delivers energy or shock when you don't really need it. All types of ICDs do have a risk of delivering an inappropriate shock. The risks of when does this happen? If the lead is fractured, if there's what we call oversensing, where that electrical impulse of how the heart relaxes is too tall, it can again see it as an abnormal rhythm when it's actually not. Or if you have other types of arrhythmias coming from the top part of the heart that look wide and are very fast, the ICD may think that this is coming from the bottom part of the heart and deliver energy and give a shock. So how do we minimize this? And again, it comes down to what type of ICD is best for you. So patients with hypertrophic cardiomyopathy, we know that over time, the heart is going to grow. And those types of what we call oversensing may become an issue if we do have a subcutaneous ICD. there are different ways to reprogram the devices, all devices, to make this a little bit safer and those risk of having an inappropriate shock go way down. But for subcutaneous ICDs, if you're not really passing all of the tests or screening, we may shy away from that one and then recommend a transvenous ICD for you, because we do have currently more ways to adjust or reprogram the transvenous ICD than we do the subcutaneous. So again, lots of this can be done with just reprogramming. If the lead is fractured or we cannot reprogram it for whatever the reason may be, we may just start discussing about changing the device location or type. So let's switch gears and talk about living with an ICD. Before you have any sort of implant or you're having these discussions, I really encourage you to talk openly with your physician or your healthcare team and say what matters to you. And nothing is too small. I have one patient who absolutely loved going to the beach, wearing crop tops, and it was very important to her to have as small of scar as possible. So we were able to adjust the location for her subcutaneous ICD just slightly, and of course within reason, to make it a little bit higher and a little bit less noticeable for her. After implant, know that there's going to be a recovery from the procedure. The true recovery is in the times of days. And then we may alter how you're able to move your arm or participate in different activities for the next few weeks. But that real recovery time is on the order of weeks. But of course, there's a mental change. Some patients come to me and say, I have such a relief that I have an ICD, I can sleep better with it. Some patients are on the other side saying, I have more anxiety, and I do have anxiety that what if I do get shocked? Now let's talk about adjustments to lifestyle. I really want, this is one website, again, there are many more out there. There are other types of videos online that you can watch as well, but asktheicd.com is a nice one that you can go and search for questions. So adjustments to lifestyle. So we know that this is a device that sends electricity to the heart. And so a magnet can interfere with this device. And when you're close to a magnet, the ICD will alert you. And you simply move away from that area, and then all the programming will return to the previous settings. Now, within our world, there are different types of magnets or things that you will come across in many electronic devices. And so, or devices with motors. So there are some that are safe to use. Some have 6 inches to 12 inches distance requirements. But this is a great site to go through and to reference later on if you have specific questions about devices. But I do want you to know it is safe to go through the airport. You can absolutely still travel. Your physician, depending on what type of device you have and your underlying disease process, may say, let's avoid roller coasters. This is a big conversation that I have with my patients. And again, the device just may get confused with all of the motion that the roller coaster provides, that it may provide an inappropriate shock. For contact sports, we want to protect the device and protect you. So your physician may be discussing or having further conversations about sports or altering which sports you're involved in. And we talked a little bit about roller coasters already. So the big question after having this information that you have to ask yourself are, am I ready for an ICD? Do I need more information? Do I need a little time to process this? And so I would encourage you again, for you and your doctor to make that decision, or you and your family with your doctor, get as much information as you can. Your medical team very much understands that this is a big change in your life, and they're there to help answer your questions.
We know that the decision to move forward with an ICD is a very large one with a lot of weight behind it. If one decides to move forward with the ICD for themselves or for their child, we've decided to break down areas of focus pre, during, and post-implant. In the pre-implant phase, it might be important to consider how is one coping overall with their diagnosis or heart condition, and then with the need or the recommendation for the ICD. Are these combined in the same time period in the sense that one is diagnosed and quickly following that, they are receiving the recommendation for an ICD placement? Or have they had a diagnosis for many years? Due to the progression of their condition, it is now that the physicians are recommending placement of an ICD. Of course, both can have their consequences in terms of impacting coping and adjustment. It's important to think through how much is it the diagnosis itself and how much is it the ICD. In this phase, it's important to prepare for procedures. Even for our youngest of patients, we like to provide them with honest, developmentally appropriate language in terms of what to expect. We like to open the door for questions and meet them where they are. They'll often guide you in terms of how much information they need by the questions they have. At this stage, it's also important to consider procedural anxiety. Patients can be anxious about a number of aspects of an upcoming procedure. Could be the IV placement. For others, it might be anesthesia and misconceptions related to that. Or perhaps it's the surgery itself and being in the operating room. It's important to put these out there and see what might be true for each individual patient. Additionally, in the pre-implant phase, we would like to encourage parents and providers to consider providing a choice. We know that this is not always feasible and that so much is out of their control during this time. But when possible, providing choice can be really instrumental in facilitating coping. As Dr. Giacone alluded to, there may be an opportunity to have choice with regards to where the ICD is placed. Perhaps not, and perhaps it's deciding which arm to have the IV placed in on the day of the procedure or other things. And so we'd like to encourage parents, caregivers, and providers to think on a small scale and also on the big scale and open the door for this conversation when possible and safe. During this stage, it also might be helpful to introduce or enhance coping tools and strategies. A great way to start this conversation with a child or adolescent is to ask, what will increase your comfort? What will have you feeling more comfortable in the days before or on the day of? You may want to introduce or remind them of their tools such as distraction, active coping, which might include deep breathing, relaxation skills, or planning for the day. Perhaps their anxiety will be lessened if they're provided with more information and answers to their question. Depending on the center that your child or you yourself are receiving care, there may be child life or other support services such as mental health providers that can be there and be present. Next slide, please. During the hospitalization, this is often a very busy time with acute recovery occurring. If there's mental health providers on the team, they are of course there to provide support, but we'd like to encourage parents, caregivers, and providers to also be considering ways they can support patients during this time. Normalizing emotional reactions, validating those emotional reactions, and opening the door for conversations and questions are great tools that all of us can use to enhance coping during the hospitalization. There's of course a focus on pain management and also beginning to think about how to prepare for the return home with the immediate recovery phase. Next slide, please. Post-implant, in that immediate recovery phase, that's an acute time. It is a time of change and a time of adjustment. It is absolutely normal for there to be some sadness if one missed out on an activity or an event at school or within their social lives. There also may be worry. There may be discomfort looking at their scar. And all these are to be expected in these initial days. When we're seeing sadness turn into more of depression, a lack of interest in things that they used to enjoy, and to note this is beyond what they're perhaps no longer able to do because of medical recommendations. Intense worry that's interfering with their daily lives, they're functioning at home or school, they're pulling back from being around their friends, or there's changes once they return to school in their ability to do their academic coursework. These are signs that it may be warranted to reach out to a mental health provider or your child's care team or pediatrician to receive a referral for a mental health care provider. At this phase, patients should be returning to school, and it may be helpful to discuss with your care team accommodations, perhaps formally in the form of a 504 or an individualized education plan, if this is warranted due to maybe changes to their PE abilities or needing to take medications at school, etc. Our team is very committed to having patients return to lives as much as possible after the implant. So returning to friends, returning to social opportunities, extracurricular involvement, and of course, school. This is a change, and with change comes a new normal. Defining that, exploring that, trying things out, looking at what can be resumed, and maybe if there are changes due to medical recommendations, where one cannot do something that they used to really enjoy, finding new activities, but caution in terms of when they feel ready so that they're not feeling pressured to automatically replace something that they loved. Next slide, please. Post-implant, we're also helping patients facilitate coping with their scars and how to maybe respond to questions about that. Physical changes if their device is noticeable with certain clothing or in certain situations such as at the beach or at the swimming pool. And changes to lifestyle. With regards to this, there may be changes in which they're no longer able to do a contact sport. We encourage conversation to explore what was it about the sport that provided them fulfillment and joy. Was it the sport itself? Was it the social opportunities in the sense that their friendships and social interactions all really revolved around that sport? Was it the sense of achievement? Was it a big portion of their identity? Just like the procedural anxieties, this can be different for each patient, and it's important not to assume, but rather to open the door for conversation and understand what was true for them. And last, if developmentally appropriate for our adolescents and maybe young adults, helping them become more independent in managing their healthcare, their medications, and making smart choices for their overall health. Next slide, please. Regardless of which phase, we hope that one of the key takeaways from today's time can be encouraging you to feel empowered, to communicate what is important to yourself if you're the patient, or to communicate what is important to your child to their care team. Asking your child what is important to you is a great opening question that helps to understand what they value and what they prioritize in their life. It may be very different from you as a parent, and having that conversation and time to reflect is important. Another great question is, how is your heart condition or the ICD getting in the way of what you want to do? Again, we can go in with a lot of assumptions based on our own experiences or what we think might be true for our children, but actually asking them directly is indicated. Next slide, please. Aside from overall coping and adjustment, we wanted to spend a moment to acknowledge that living with an ICD can have mental health challenges. When we look at the literature, some studies show ICD patients function no differently than the general population, whereas others show higher levels of depression, anxiety, and sleep disorders. When looking at quality of life, which includes both physical and psychosocial functioning, some studies suggest that they are lower, the ratings are lower in pediatric ICD patients when compared to normative groups and other patients with congenital heart disease or chronic illnesses. Next slide, please. It's important to put this in context, given that it's 2023 and all the tremendous stress that everybody has faced in the last few years. Youth mental health in general, of course, has been affected. There was a declaration of a national emergency in child and adolescent mental health from the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association in 2021. Here, we saw elevated rates of anxiety and depression, where 1 in 4 youth were reporting significant levels of depression, 1 in 5 youth significant levels of anxiety, and these rates were much higher than pre-pandemic estimates. Next slide, please. A few years ago, we were motivated to understand what is on the minds of our pediatric ICD patients, and we conducted a needs analysis. Their reports, when ranked by endorsement frequency, indicated understanding their cardiac event, understanding medications, and how the ICD will change their lifestyle were the top frequently endorsed needs. When asked about the priority, they indicated understanding how the ICD will change my lifestyle was first, followed by following the medical recommendations, understanding their cardiac event, medical decision-making, and understanding their medications. Next slide, please. We asked the same of parents, and parents, in terms of ranking by endorsement frequency, indicated at the top, or the most commonly endorsed, was frustration of my overprotectiveness, my child having low self-image or low self-esteem, my child doing household activities or chores, and my child feeling depressed or anxious. When asked about the needs that they endorsed in terms of what were the highest priorities, parents indicated first, my child feeling depressed, my child having low self-esteem or low self-image, frustration of my overprotectiveness, followed by my child doing household activities or chores, and my child feeling anxious. Next slide, please. So we heard different things from parents and from patients, which I think highlights the need to check in with both and to not come in with assumptions that the ICD is affecting everyone in the family in the same way. We spoke briefly about youth mental health, and we wanted to acknowledge that the ICD, the diagnosis of cardiomyopathy, living with a heart condition, can also affect parents. When looking at the literature, we've seen that parents of children with heart disease are more likely than the normative population to report excessive parenting stress, where 1 in 5 reported clinically significant levels. We also know that parents of children with congenital heart disease report psychosocial problems, including depression and anxiety. Last year, we published a study in which we assessed for symptoms of post-traumatic stress disorder. In 20 out of 43, nearly half of our parents of our pediatric ICD patients met the cutoff for post-traumatic stress disorder on the screening measure. This highlights the mental health needs of both patients and parents in this population. Next slide, please. 2 years ago, the American Heart Association issued a statement that encourages a care model that integrates mental health care in cardiology clinics and teams to provide the best quality of life possible. This is an aspiration for many centers and a work in process for many. A number of years ago, we established clinic-based supports where a psychologist, myself, and postdoctoral fellows are present in our EP clinic to provide support to our ICD patients. It's important to note that this has evolved over the course of many years and started off with a motivated individual and motivated patient, motivated care providers coming together to form an initiative within our hospital. I want to highlight that this didn't happen overnight, and we still have growth to do, but I'm really proud of some of the initiatives we've done, one of them being our annual Connecting Patient and Family Day, with some pictures highlighted here. It's provided for our ICD patients. We provide education, a day of fun, and most importantly, an opportunity to connect with one another. Next slide, please. While all of us continue to move towards the recommendations provided in that statement, there are resources out there to help, regardless of what your center has with regards to specific mental health resources. There's camps for youth with heart disease, and many times these also offer parent and sibling branches or unique camps as well. We encourage you to ask your local care team for what camps are provided in your area, as they exist across the country. There's also excellent support groups that are offered through nonprofit organizations such as CCF. CCF offers CCF Connect, an online discussion for members, a parent ambassador program in which trained parent volunteers provide resources, information, and peer-to-peer support. And for kids, there's the Heart Buddy program, which matches kids with cardiomyopathy to provide friendship and support. Here are two handouts that are very helpful for our patients and families, put out by Circulation and the American Heart Association. Heart Smart Guide for young patients with cardiac devices. And my child needs or has an ICD. What should I do? These can be found online. Next slide, please. Furthermore, the advancement of technology has enabled anybody with a smartphone or tablet to be able to access tools that we often utilize in clinic during mental health care treatment. While we have no relationship and do not endorse any of the following apps, books, or websites, we did want to highlight that these have very valuable tools and resources and can help one manage stress and anxiety by learning deep breathing, guided imagery, meditation, mindfulness, etc. Next slide, please. We've also created a list of books that can help parents and children or adolescents when they're showing symptoms of anxiety or even depression to work through with workbooks and skill building with their parent or by themselves, perhaps until they're able to establish care with a mental health care provider should that be necessary, or perhaps learning some of these skills for subthreshold symptoms is appropriate. Next slide, please. We are excited to partner once again with CCF to help establish a fact sheet that will contain the questions and answers from today's webinar, in addition to listing the resources we briefly touched on and many more. So please stay tuned and look for that member resource library in the near future. Here are our references for our slides for the next few. With that, we just wanted to say thank you.
That was a wonderful presentation. Thank you so much, Dr. Giacone and Dr. Schneider, for this wonderful information. We are going to open the question and answer session. We do have a fair amount already submitted, so please rest assured that if we do not get to your question in the next few minutes, we're going to make sure that all questions are answered, even if they are offline, and we'll communicate back the responses to our attendees. And just a reminder that the doctors will be able to comment on, questions of a general nature and will not be giving specific medical advice or guidance for particular specific cases. But here's first question is, for risk classifications in the pediatric hypertrophic cardiomyopathy population, you mentioned Z-scores for septal thickness. What Z-score would be considered an indication for needing an ICD?
So great question. It truly depends. It's usually a Z-score about 5 to 6 in our pediatrics of the thickest area of the septum. There are a few separate individuals that have performed studies though, and we are looking or did look at where in the location of the thickness in pediatrics versus other adult patients may provide also a little bit more information. And so if you have a significant thickness in those regions, the Z-score may decrease a little bit. And so they may start talking about a Z-score of 4 if it's an area that we know are at higher risk of having arrhythmias. And so usually that's more of the inferior posterior wall. But I would say in your mind about 5 would be the Z-score that you're thinking about.
Great, thank you. You referenced battery life earlier, but does each different ICD have varying battery life within the different types?
Yeah, also a great question. The generators are also a different size. I did want to make a mention of that. So the subcutaneous ICD generator is a bit bigger than the other types of generators. And the reason for that is when it delivers a shock, it actually requires more energy to produce that effective shock than the transvenous ones do, or even the epicardial ones. Both are equally as effective. We know that when they deliver a shock, it is effective. So despite that energy difference needed, it performs the same way. So because of that bigger generator of the subcutaneous ICD, that battery lasts again about 8 years or so. And then for the transvenous one, again, it's about 8 to 10 years. The transvenous device, if you do need pacing, which I didn't talk about, and so one thing that we consider is, do you as a patient need pacing of your heart? On other occasions, we will then say, let's do the transvenous or epicardial ICD because the subcutaneous one cannot pace. The reason that I bring that up is because if you have a higher pacing need, you can use more of that battery faster. And so then the battery life will shift down a little bit for that.
Great, thank you. Is there different recovery times for the transvenous versus subcutaneous implant?
Also a great question. They're actually pretty similar. And so usually, and again, this is institution dependent, but usually for our centers, it is, you will have the procedure one day, stay overnight, making sure that pain is well controlled during that time. After that one day recovery time, you will be able to go home if everything is looking good. And then it's really the few weeks afterwards, there's a little bit different activities that you can do with different ICDs. So for the transvenous one, because it is higher on the chest, we really talk a lot about not lifting your arm fully over your head for at least about 6 weeks or so. Although you can have mobility of your arm, we will put you in a sling to kind of remind your body for that first few days not to lift your arm over your head or kind of do big motions. And really, again, that's just to protect the healing up here. Whereas the subcutaneous ICD is a little bit different. It's below the arm. And so those types of motions aren't as restrictive for as long.
Thank you. Excuse me, how would you define extensive scarring on an MRI? Is there a certain metric or percentage to look for?
Such a great question. This question is a little bit debated within our field. And so usually what happens in an MRI, which is a very detailed image of the heart, a longer study, usually in there for at least 45 minutes to an hour. And what you do is you give a bit of contrast or a dye that is washed in the heart, and this actually goes through an IV, and the area of scar, that dye sticks to it, and it doesn't wash out as quickly. And so you might hear this delayed contrast or delayed gadolinium enhancement, and that really highlights the scar within the heart. So usually over 30 to, in some say 50% of scarring or delayed enhancement of the heart is considered severe. You can have this in patchy areas, or you can have it more globally. So the true definitions, again, vary a little bit based off of which paper you read.
Thank you. We have a couple more questions, which we're not going to be able to cover. I'm going to try to squeeze one last question in here now, and then we'll connect offline for the remainder. But a question for you both. In a family with a history of disease, where there's a history of sudden cardiac arrest and history of death, an electrophysiologist is recommending an ICD and the cardiologist is hesitant due to age considerations for the child. What is your guidance for a family interested in getting a second opinion?
So great question. I think it's always I first of all want to commend you for being an advocate for your family is the biggest thing. Physicians always are open to having second opinions. Of course, this is for you. We're providing some advice. And us ourselves usually talk as a community. So sometimes there are cases that we do very closely have to weigh risks and benefits of each case. So do not feel wrong or like you can't get a second opinion.
Thank you so much. Again, I wanted to thank you both for spending the time and your partnership with us. We're excited to continue our work together for the fact sheet, which we will be sure to circulate when that's available to everyone. Just really enjoyed our time today, and I think that this was a great wealth of information. I wanted to just close us out by reminding everyone that our recording is going to be on our website and our YouTube channel. Please mark your calendars for our next webinar, which is coming up in June, and it's on exercise, sport, and cardiac rehabilitation. So there may be some follow-up questions regarding ICDs and exercise and sport. So please do join us for that session as well, and just continue to stay connected. I put a few resources in the chat as well for CCF, so be sure to check those out. And again, Drs. Giacone and Dr. Schneider, I just wanted to thank you for your time and expertise with us.
Thank you so much.
Thank you.
Thanks, everybody. Have a great day.